Now let's look at the cycle of maturation starting from the primordial follicle all the way to the tertiary or mature Graafian follicle. So as you recall that when a person is born, a female is born, she has all the oocytes that she'll ever have in her life. And they're all residing in these primordial follicles that are arranged in these egg nests. And so this is what a primordial follicle looks like. We have a primary oocyte surrounded by follicle cells. And then when puberty occurs and we get that first stimulation by follicle-stimulating hormone, some of these follicles will begin to develop. And they will develop into primary follicles. And what will happen when they develop into primary follicles is that the follicular cells or the follicle cells will basically change their morphology into these rounded granulosa cells. And the granulosa cells will promote the maturation of the oocyte, and they're little microvilli on the inside of these granulosa cells, and the oocyte itself has some microvilli, and that's promoting the exchange of material across the two. Now, that will create what is called the zona pellucida, or the zone that is the white zone, or the white is not exactly the right word, transparent zone. So the transparent zone. So this zona pellucida is going to be this little interface between the granulosa cells and the oocyte. Now, we also have these little thecal cells, and these are box cells. And these cells are hard at work making androgens. Yes, I said androgens. So we're talking about things like androstenedione, testosterone, and these kinds of things, because it is these that will be the substrate to form the estrogens, the estradiol, and these kinds of things. So remember that female hormones are actually male hormones that have been converted. And that enzyme that I talked about last time called aromatase is in these granulosa cells. So the granulosa cells will use the enzyme aromatase to convert the androgens made by the thecal cells into estrogens that will then promote the maturation of the oocyte, and will also be, as we'll see a little bit later on, will regulate the ovarian cycle, which in turn will regulate the uterine cycle. And all of this is going to have feedback loops with the pituitary and the hypothalamus, and so we have this very complicated choreography of hormones that will be going on in the cyclical function. All right, so what happens after we have a primary follicle? It will then mature into a secondary follicle. Here are thecal cells again. We see that our zona pellucida is beginning to expand a little bit. We're getting some fluid that is accumulating with inside the follicle. And this is called follicular liquor, or liquor folliculi is the fancy term for it. And eventually it will fill the whole follicle. And at that point, we will have this antrum that's full of this follicular fluid, and we have granulosa cells all around this thing in the inside of the follicle, and they will accumulate around this, what is now a secondary oocyte. So basically what's going to happen is by this time, when we get to the tertiary follicle, the oocyte will have started to undergo meiosis II. And then there it will stop, and it will be suspended there. So up to the secondary follicle, we had a primary oocyte, but now by the time we get to the formation of the tertiary follicle, then our primary oocyte will have started to undergo meiosis II, and it's now a secondary oocyte, and this is going to be what's going to be released into the pelvic cavity. So we see this accumulation of granulosa cells around the oocyte, and this will be called the corona radiata. And again, we've probably seen this term before elsewhere, but it is basically a little halo or crown around the oocyte. And this is now a secondary oocyte. This tertiary follicle is sometimes called a mature follicle or a mature Graafian follicle. Now, once this thing is ready, so here we've sort of traced the evolution of this thing from a primordial follicle. And remember that the diagram is showing all these different phases. In reality, these things don't move around. They just simply stay in place and undergo this development. So a primordial follicle will have started here, then will have become a primary follicle, then a secondary follicle, then a tertiary follicle. And then at that point, under the stimulation of luteinizing hormone, and that hormone gets its name because it's going to cause ovulation, and we're going to see the expulsion of the oocyte along with the corona radiata and some of the follicular fluid, and that's going to leave the ovary and be swept into the uterine tube. And then because of LH. And then this whole thing will involute and become the corpus luteum. So the LH, luteinizing hormone, is what causes ovulation, and of course is what causes the tertiary follicle, or what's left of it, to become the corpus luteum, and hence the name luteinizing hormone. Then our corpus luteum will start the second phase of the ovarian cycle, and that will be the luteal phase. So all of this first phase that encompasses the maturation of our follicle and the expulsion, well, the first phase is the maturation of the follicle up to a tertiary follicle. That's the follicular phase. Then we have ovulation, which is the differentiator between the two phases. Once we have ovulation, then of course our follicle will involute into the corpus luteum, and we have our luteal phase. And the trigger that caused the shift is luteinizing hormone. All right, so we have the corpus luteum, which will now be hard at work making progesterone. And progesterone is going to be a signal to the uterus to prepare the uterine lining to accept an oocyte. And should that oocyte get fertilized, then that oocyte will have certain needs that will need to be met. And so that's when the uterine lining starts preparing to receive the oocyte. And if nothing ever happens, and the end of the cycle is reached, the end of the luteal cycle, and nothing happens, no fertilization happens, then the corpus luteum will involute and become the corpus albicans, which is just this little scar tissue remains. All right, so once the egg leaves the ovaries, it has to get to the uterus. So it's going to travel to the uterine, through the uterine tubes, which are lined with cilia, and the cilia will sweep the oocyte along. You can also have some peristalsis in here because we've got some smooth muscle in here, but we're going to carry the oocyte along the uterine tubes to the uterus. All right, so we've got these segments. We've already talked about some of them. We've got the infundibulum, the funnel-shaped part right there at the opening, and this has the fimbriae that extend out into the pelvic cavity and are going to reach out and sort of wave that oocyte into the infundibulum. And that's cilia are going to beat towards the middle segment. And then we're going to have the ampulla. And this is that middle section. And the isthmus is the short section between the ampulla and the uterine wall. So here we have the infundibulum with its fimbriae, the ampulla, which is this part right here, and then the isthmus, which joins the ampulla to the uterus. All right, so when we look in the uterine tube, we'll see that we have lots of mucin-secreting cells, and we're going to have some smooth muscle, concentric layers of smooth muscle that are going to help move the oocyte towards the uterus. And if we look at it, we see that it's not exactly a round lumen. It has this kind of shape here. So our lamina propria is out here. Here we have columnar epithelium. And we're going to have cilia that are going to be beating along in here. We've got smooth muscle, and this happens to be taken from the isthmus. All right, so we also have these microvilli, mucin-secreting cells, which are basically interspersed throughout the columnar cells that are going to be, well, that have cilia, and the cilia are going to beat. So we're going to have columnar epithelium in here. Some of them have microvilli. This is what's going to be secreting mucins. And then we have the cilia, which are going to beat and move the oocyte towards the uterus. All right, so we have both ciliary movement and peristaltic contractions. And basically, before ovulation happens, there are going to be some pelvic nerves that are going to start turning on this beating pattern of the cilia and initiate peristalsis. And so that's going to allow for the egg to be moved along the uterine tube as soon as it enters into it. All right, so here's the kicker. In order for a zygote to form, you have to meet the sperm within the first 12 to 24 hours of ovulation. Otherwise, nothing's going to happen. So these gametes are not long-lived. So basically, people who are trying to get pregnant will try to have the coitus somewhere between 3 and 5 days up to and including the day of ovulation. Before or after that, you're not likely to have the meeting of the sperm and the egg. So basically, you've got to have that fertilization happen within that window. If it doesn't happen in the window, then it's not going to happen. So typically, the sperm and the egg will meet somewhere between the ampulla and the isthmus, right at the boundary typically. And then it'll take another few days for that zygote, which will then undergo several more cell divisions. It will take a few days for it to come in and implant into the uterine wall. Along the way, we're going to have these specialized cells called PEG cells. And these do not have cilia, but these are going to be secreting nutrients for the oocyte. So they're going to have lipids, glycogen, these kinds of things. And this is going to help supply the oocyte. And if there's a meeting between the sperm and the egg, it's going to help the pre-embryo get the nutrients that it needs. All right, so once it gets to the uterus, it's going to implant there. And so for the first 1 to 8 weeks, we're going to call this the embryo. And after that, 9 weeks through delivery, it is now the fetus. And the uterus is the place where this thing will gestate. So it's going to give it protection, nutrient support, waste removal, and so forth. So this organ is fairly pear-shaped. And in most people who aren't pregnant, it's pretty out of the way. It usually bends anteriorly. We call this anteflexion. Sometimes they can be retroflexed, but that's very rare. And if an individual has a retroflexed uterus, as soon as they get pregnant, eventually it usually flips over during the pregnancy. So we got a couple of things that are going to hold the uterus in place. We've got uterosacral ligaments that are going to prevent inferior and anterior movement. And we're going to have round ligaments that's going to restrict posterior movement, and cardinal ligaments, which are also going to prevent inferior movement. So if we look at where these things are, here's the uterosacral ligament. Now, mind you, we're looking down. Here's the anterior part. Here's the uterus over the bladder. It's anteroflexed. Posterior, here's the rectum. Here's the last part of the sigmoid colon. So here we see the uterosacral ligaments are going from the posterior aspect of the inferior part of the uterus to the back part of the pelvic wall. Then we have got the round ligaments of the uterus, which will actually connect down into the inguinal canal in the female. And then we have got the cardinal ligaments, which are basically holding the uterus to the floor of the pelvic cavity. Here we've got the broad ligament, which, as you remember, is our mesentery. This is going to be our mesovarium here. This is going to be our ovarian ligament. And here's going to be the suspensory ligament right here. And this is looking top down, of course, into the pelvic cavity. All right, so the uterine body is the biggest part, and the fundus is the dome-shaped top part. We've seen the term fundus before, and it's going to be superior to where the uterine tubes come in. Now, if we talk about the blood supply to the uterus, we have the uterine arteries, and these are going to be branches of the internal iliac arteries, and we're going to have the ovarian artery. And this is our gonadal artery. This is the one that, as we see in the cat, arises from the abdominal aorta, and the female cat goes laterally out to the ovaries, and then the male cat turns and descends through the spermatic cord. So when we talk about the gonadal artery in the female, it is the ovarian artery. And we're also going to have some vessels, veins, and lymphatic vessels as well. A lot of these, as we will see, will travel within that mesentery, the broad ligament. All right, so we've got several nerves of the uterus. A lot of them are coming from the hypogastric plexus of the sympathetic nervous system, and remember our parasympathetic nervous system. Those sacral segments 3 and 4 are going to supply the uterus for the parasympathetic division. I'm not going to talk too much about segmental blocks, the anesthetic procedure that can target spinal nerves T10 through L1. This is also known as an epidural sometimes because this will basically put the sensory sensation of this part of the body to sleep so that childbirth is not painful. All right, so when we look at the inferior end of the uterus, there is the cervix, and that is the part that extends into the vagina. Separating the main body and the cervix will be the isthmus. We'll see that in just a second. And the outside of that, as we've seen before, has the external os. Then we also have an internal os inside that we'll look at in the pictures in just a second. And then we will see the cervical canal, which is basically the passageway that's going to lead from the uterine cavity of the body into the vagina, and the internal os is the part inside. It's much easier to see it in a picture. So here we have the uterine cavity. Here we have the myometrium. Here we have the internal os, the external os. All of this is the isthmus right here. This is the cervix. This is the fornix. And we can see that we have this endometrium in here. And the myometrium is quite large, comprising the bulk of this organ. And it's going to be much larger in people who've been pregnant, and it certainly enlarges during pregnancy as well. So we can see some of the arteries. Here's the uterine artery and vein. Here is the ovarian artery coming in. And we'll see another picture of it in just a minute. And then, of course, we have where the cervix extends into the vagina here. The vaginal wall has these rugae, as we remember from before. And that's, of course, so that if there's childbirth, there'll be enough room. The organ can distend enough for the child to pass through. Now, interestingly, the uterus can enlarge quite a bit, 4 or 5 times what it is in just the non-pregnant female. All right, here is another picture of it. Here you can see the broad ligament. You can see these arteries and veins traveling into it. And we can see our mesovarium here. So the uterine wall itself has the outer muscular layer, which is called the myometrium. And as we said, it comprises about 90% of the organ. It's arranged in 3 layers. And it's not the same outer longitudinal layer, inner circular layer, and inner oblique layer that we've seen before. As a matter of fact, it's complicated. So we'll get into that in just a minute, but we do have 3 layers, and they are sort of along that plan. The oblique layer really isn't very oblique. It's got crisscrossing fibers all through it, and it's more in the middle than it is in the internal area. So really, it's quite complicated, the arrangement of the myometrium. I'm not going to get into too much detail about it, but obviously the myometrium has to be strong enough to expel the fetus, the baby when it's born. Now, the inner layer is the glandular layer, and that's called the endometrium, and that's the part that's going to change with the uterine cycle. The perimetrium is basically a membrane, serous membrane, that's continuous with the peritoneal lining. And so this is going to cover the fundus and the surface of the uterine body and the isthmus. So there's a picture of it somewhere. I think it's back here somewhere. No, not yet. All right, so let's have a look at the myometrium. As we said, that's the thickest portion of the uterine wall, about 90% of the mass. It is arranged into longitudinal, oblique, and circular layers, but they're not that well defined. So you couldn't really say, oh, this is the longitudinal layer. In fact, there's quite a bit of crisscrossing and other things that go on, especially in the middle layer, which is more like the oblique layer. And of course, that's going to move the fetus out of the uterus and then into the vagina. At this point, hopefully, if it's a normal breech, the baby's head will be first, and then it's fairly easy to get the baby out at that point. So the endometrium, somewhere around 10% of the uterine mass. This is going to change throughout the uterine cycle, and we've got basically vascular tissue, so lots of blood vessels in here, and lots of glands in here. So we're going to have lots of uterine glands that will become particularly prominent during the second half of the uterine cycle. And we're going to see that estrogen, which will be produced by those follicular cells or now they'll be granulosa cells in the follicles, will be causing uterine glands, blood vessels to change in the first phase of the uterine cycle. So the first phase of the uterine cycle will be tied to the follicular phase of the ovarian cycle while this estrogen is being produced. So let's have a look at the endometrium. We have the endometrium here, and here you can see these deep glands, and the rest is this mucosa, this epithelial cells with the lamina propria and so forth. We're going to have a lot of vasculature in here. So we're going to have our uterine artery out here, and from the uterine artery, we are going to have arteries that will feed into the uterine arteries, and these will then have some arteries that branch off called arcuate arteries, because they basically will surround the outside of the uterus. Then we're going to have a radial artery, so named because it radiates from the arcuate artery, and then we're going to have these spiral arteries that will supply the actual endometrium, and these are the things that will sort of degenerate and slough off at the end of the uterine cycle. All right, so the endometrium has a functional zone, a basilar zone, and the functional zone is the part that's going to get sloughed off every month, and the basilar zone is going to be the part that's going to regenerate every cycle. Here we have the uterine glands, and we're going to have some simple columnar epithelium out here, and then we have the lumen of the uterus out here. All right, so the functional zone is going to contain most of the uterine glands, and it's going to contribute to most of the endometrial thickness. And this is the part that's going to change during the menstrual cycle. The basilar zone, which is this part right here, is going to be the part that's going to regenerate. And it's going to contain these terminal branches of these endometrial glands. So this is what will allow them to regenerate every cycle. So we have the arcuate arteries that we've already saw encircling the endometrium. So basically, if we go back up here, really it's going to encircle the endometrium, but remember the arcuate arteries are going to be these ones that are making an arc around the entire uterus, and they're really in the muscular zone, so they're in the myometrium, but they encircle the whole endometrium, and then they have the radial arteries that are going to branch from the arcuate arteries and give rise to these spiral arteries. All right, so we have the radial arteries. We first have the straight arteries that are going to be in the basilar zone, and the straight arteries will then supply the spiral arteries, which are basically elongations of the straight arteries, into the functional zone. So basically we're going to have the basilar zone not change much, but it's the functional zone that's going to change during the uterine cycle. So this is going to be due to sex hormones rising and changing levels, and this is going to produce the various features at various times of the uterine cycle. So as we've said, the uterine cycle on average lasts 28 days, and some people it's 35 days, some it's 21, and this is sort of the standard deviation, but typically it's about 28 days. And so we have really three phases. The first phase is menses. This is when the whole thing ends, basically, and you get rid of the functional zone of the endometrium if there hasn't been a pregnancy or if no fertilization has taken place. The proliferative phase is that first phase that's going to occur roughly simultaneously with the follicular phase of the ovarian cycle. So the ovarian cycle is going to occur, menses will occur at the beginning of that, and the proliferative phase of the uterine cycle will occur simultaneously with that follicular phase of the ovarian cycle. And then once we have luteinizing hormone and we've ovulated and we've transitioned into the luteal phase, the corpus luteum will now start producing the progesterone, and that will basically turn the uterine cycle from the proliferative phase into the secretory phase. So the luteal cycle or the luteal phase of the ovarian cycle will correspond roughly with the secretory phase of the uterine cycle, and the follicular phase of the ovarian cycle will correspond roughly with menses and the proliferative phase of the uterine cycle. All right, so menses is where basically the degeneration of the functional zone happens and it's lost. And what happens is the spiral arteries will basically constrict and pull away from the tissues of the functional zone, and so that tissue dies. So there's no oxygen or nutrients to it, and it dies, and then basically it's lost. And some of these walls of the spiral arteries will also rupture, and basically all of that tissue will be lost. So we know what happens, then all that stuff is lost through the external os in the vagina, and then it'll start regenerating again during the proliferative phase. All right, so here is the basilar zone of the endometrium, and this up here is going to be sort of the functional zone, and this is during menses, so this is when we're losing all this tissue. So this endometrium is going to be thinned out at this point, and we're going to lose most of the functional zone. So this is a process where all this is lost. It lasts anywhere from 1 to 7 days. It varies greatly from one person to another, and at different times of the life. All right, the proliferative phase is where the epithelial cells are going to start to proliferate. So we're going to have these uterine glands, we're going to have this endometrium. So these epithelial cells will multiply and start spreading across the endometrial surface and sort of restore the uterine epithelium. And then we're going to have some more growth of vascular phase, so that we'll have the regeneration of some of these spiral arteries. And then, as we say, this is happening at about the same time that we have our primary and secondary follicles in the ovary. So this corresponds with the follicular phase of the ovarian cycle. Now, at this time, this proliferative phase is going to be stimulated by the estrogens that are being secreted by the ovarian follicles. And eventually, we're going to have the entire functional zone. It's going to be highly vascularized at this point. We're going to have these spiral arteries that are moving towards the lumen, the inner surface, and these are going to be supplied from those larger radial arteries, and then that are coming from the arcuate arteries that are within the myometrium. And then we're going to see that the functional zone is being restored. Here we have some uterine glands. And then when we get to the secretory phase, this is when those glands will really, really enlarge, and they'll start increasing lots of the rate of secretion. And so we're going to have more elongation of those arteries, those spiral arteries. And this part of the phase, the secretory phase of the uterine cycle, will begin at ovulation. And it will continue as long as the corpus luteum is active. And the whole thing that's really supporting the secretory phase is progesterone. So progestins are going to be the thing that's going to promote the secretory phase. And it lasts anywhere about 14 days, typically in a 28-day cycle. And then when the corpus luteum stops producing progestins, then the secretory phase will stop, and then menses will occur. So here is a picture of the functional zone. You see all of these glands in here and how much they've proliferated. And you can see sort of the difference during the secretory phase compared to, say, the proliferative phase compared to menstruation, where the whole functional zone is lost. Then during the proliferative phase, it starts to be restored. You start to get some of these uterine glands that are starting to be formed here. But right now, we're just concerned with repopulating the functional zone of the endometrium. And then during the secretory phase, that's when all these glands will mature. We'll see large amounts of glands and thickening of the endometrium. And then this will continue throughout someone's life. This cycle will continue. This ovarian and uterine cycles, which are very tightly linked, will continue from the first uterine cycle, beginning usually around age 12. So it used to be 12 and a half was the average age. Now, because we have so much hormones and stuff in food, and estrogen mimics in food and other things, other sources, it's that age has become younger now. So that's one of the problems that we have with some of the environmental toxins, is that we have precocious puberty in a lot of females. And we also have delayed onset of puberty in a lot of males because of this. But that's an aside. But the beginning of the menstrual cycle is called menarche. And menopause basically happens as the end of the menstrual cycle. And this is when the uterine cycles stop and the ovarian cycles, basically, you've lost most of your follicles by this point. So by menopause, there are very few follicles remaining. This can be anywhere between age 45 and 55. Of course, if people start taking hormone replacement therapies, then that can sometimes prolong the uterine cycles. Although someone may not be fertile, they still may be having their uterine cycles. All right, so amenorrhea is a condition where you don't have menses and you don't have the menstrual cycle. So amenorrhea can be due to a failure to initiate menses or this whole cycle, and that can be caused by hormonal deficiencies. It can be caused by the fact that in some cases, some females are actually genetically male, as we've discussed earlier. They will never be functionally able to have children. And then we can have secondary amenorrhea, which is an interruption of the uterine cycle. And they say here because of physical or emotional stresses. Usually, sometimes it can be due to very high stresses. So, for example, when a war is on or something like that, or an epidemic, sometimes the uterine cycle will stop. And of course, that makes sense because the host, the female, is not really going to be able very successfully to supply the baby with nutrients if she herself isn't getting enough nutrients to keep herself alive. So obviously, if the potential mother is in danger of not being able to continue homeostasis for lack of food or supplies or whatever, obviously these secondary functions, these reproductive functions will stop. And another thing that happens is we see it in athletes often. So people who have very low body fats will often have secondary amenorrhea. And A means an absence of. Menorrhea is basically menses. Primary amenorrhea, again, is if somebody at puberty fails to initiate menses, so it doesn't happen. In some cases, it can be delayed in places where people are exposed to lots of stresses. It may be delayed to age 15 and even later. So there could be a number of reasons for amenorrhea. All right, so once the child is out of the uterus during childbirth, it will enter the vagina, which is this elastic muscular tube, and it's going to extend between the cervix, which is that projection of the uterus into the vagina, and the vestibule. And the vestibule is the opening out into the world. And so basically, we've already talked a little bit about all of these things. We've talked about what the fornix is. It's the recessed area around the cervical portion. And fornix means arch or vault. Actually, it literally means vault. And so it makes this kind of vault-like structures between the walls of the cervix and the vaginal wall. All right, so the vagina also has its own blood supply, again from the internal iliac arteries, and the uterine arteries as well, and veins will supply the vagina as well. So again, we have the hypogastric plexus and sacral nerves will be innervating the vagina, and branches of the pudendal nerve, which, as you recall, is part of the sacral plexus. The pudendal nerve is the one that supplies sensation to the external genitalia and also innervates many of the pelvic muscles in the lower pelvic cavity. All right, so we've got the functions of the vagina, obviously, to get rid of any of the endometrium that's being shed off of it. So that's one thing. Also, the spermatozoa have to have a passage up to the oocyte, which at that point will have been released within 12 to 24 hours from the ovary. So it'll be somewhere in those ovarian tubes, so in the fallopian tube somewhere, and that's generally where the sperm will meet it. But in order to get there, it has to go through the vagina, through the uterus, and up through the oviduct as well. And finally, it's obviously the birth canal. So this is where the child has to pass from the uterus to the outside world. And this is why it's so highly distensible, and this is why it's elastic and has all this rugae in it, so that it can expand when the baby comes through. All right, so the vaginal wall also has blood vessels and layers of smooth muscle as well. We're going to have some secretions by some cervical glands of the uterus, and we're also going to have a permeable epithelium that allows water to move across it. So we've got plenty of resources to create mucins, mucus, and other things that are going to allow for the easy expulsion of things through the vagina. All right. The hymen is this epithelial fold that partially blocks the entrance to the vagina, and it usually doesn't stick around very long. So no, it's not a reliable measure of virginity, not at all. In fact, it can be ruptured long before the first intercourse or even tampon use. It can be ruptured just by physical activity. And it's highly variable in individuals. So in some cases, it might even be hard to find if someone were looking for it for whatever reason, to test for virginity or whatever else. But for many, many years in many cultures, the presence of this was a test for virginity. And it turns out it's a completely bogus test because anything can damage it. And it's really not an important structure at all in terms of the function. So it really doesn't matter much. It may help prevent infection early on, but other than that, it really doesn't serve much of a use.